Today, we're talking about burns. Burns. The trick about burns is there's not really much to do from a testing standpoint. A lot of this is truly, you look at it, determine if it's a first-degree burn, you don't do anything. Third-degree burn, you have to do surgery. Second-degree burn, figure out which one you're going to have to do, outpatient management or surgery. But there's no test. There's no MRI, there's no CT scan, there's no anything like that. So this lecture is going to focus on two things. One, determining what a burn is, what makes it first, second, third-degree burn, and management. How do you take care of it? We're going to address another thing is something called the Parkland formula. That's really for medical students or physicians or residents or attendings or emergency room physicians when you're trying to manage a burn that comes into your office. Now, first let's talk about skin and burns. Quick refresher, from a skin standpoint, you have the epidermis, dermis, and subcutaneous tissue. This is the stuff on top, this is the white meat, and this is the fat underneath. The most important thing about a burn is determining whether it is in this deep or this superficial. Treatments for first degree and second and third degree are very simple. First degree burn down to the epidermis, very superficial. Think of this as steam that blows on your arm or your hand and hurts for a little bit, or a skin burn from sun tanning. So using, I guess I saw this video, this guy rubbed olive oil on his skin while he was out in the sun or something like that to get a really good one. I don't really know much about tanning, but if you get a superficial burn from sun tanning, that's probably the most common example of a first degree burn. Second degree burn is the epidermis and dermis are involved. So you kind of go down into the second layer of skin. We split this up for two reasons: the superficial versus deep. A superficial partial thickness dermis burn can be treated almost like an epidermis burn, but a little bit more. Versus a deep second degree burn usually ends up being treated like a deep third degree burn, which requires surgery. The difference between these two, between a superficial and a deep partial thickness burn, is determined by how well the burn is assessed in the first place and how it's managed initially. This is pretty much where the majority of burn care focuses, because you can take a superficial burn and turn it into a deep burn that requires surgery, or if you give it the right support, you can take a deep thickness burn, turn it into a superficial burn, and not require surgery. So this pretty much is the line in the sand that we talk about with surgery as to whether you're going to have to do something or not. Third degree, it's when you burn something, the dermis completely sloughs off or is dead, and you get into the subcutaneous tissues, the fascia, the bone. There's a fourth degree burn they talk about, but for this, we're not really addressing that. Now, burns include a lot of different things. Heat, of course, burning, fireplace, fire for crackers, heating irons, curling irons, ironing clothes, flash burns when you're cooking. Anything that has heat causes a burn. Electrical discharge, like sticking your finger in a light socket, grabbing a downed power line, stuff like that, or linemen's, which is probably one of the most dangerous jobs in the United States. They're at risk for this if they touch two wires at the same time with their finger on the power line. Friction, rug burns, you see that a lot of times in car accidents, you see it on knee injuries, you see it on anytime you have friction rubbing on something. Chemical burns, spilling, hydrochloric acid, changing your battery, leaving the little pieces that are on there on your fingers too long, and radiation. Radiation will cause burns. If you get radiation burns, you have a whole host of other problems, but it can cause them. A lot of the burns that you see from radiation these days are from people that are in industrial exposures. You used to see them sometimes when we were doing radiation treatment for cancer. But with the advancement of the type of machines we use, the way that we dose the radiation, you don't see those radiation burns as much. That pretty much covers all of the ways you get burns. You could get burns by frost. We didn't talk about that. Frostbite can also kind of sometimes go into this. It's a little different entity, but you can get superficial burns from ice as well. Now, once you burn yourself, the most important thing is to get yourself out of that situation. So if you're near something that's burning and that's how you get it, remove yourself. If it's a chemical burn, call the poison control hotline and figure out what do you need to do to neutralize that, or just rinse it off with water. Some elements like sodium can react with water and make it worse. So you have to be careful and just make sure you know exactly what you were burned with. After all that's done, you either have to decide whether you're going to go to the emergency room, your primary care doctor, or just follow up with a local burn specialist or burn clinic. A good rule of thumb is if you have something that is the size of this, so if you look and make a circle with your hand, if your burn is smaller than that, then you do not need to go to the emergency room. Even if it's a deep 3rd degree burn, following up with your primary doctor is not going to change management. So if it's this big, you can wait until the morning and go see someone, apply ice or keep it cool, do Tylenol, Motrin. If it's bigger than that, or you're worried about it being a deep 3rd degree burn, going to the emergency room is absolutely reasonable. Call 911 if you're in danger. When you walk into the emergency room, they're going to assess whether it's a 1st degree burn, superficial 2nd, deep 2nd, or 3rd degree burn, and then decide whether they're going to manage you as an outpatient, or they're going to call a burn specialist in, or they're going to transfer you. Traditionally, burn specialists are either plastic surgeons or general surgeons. Now, after they assess whether or not you have a significant burn, something is greater than 5%, and we have to worry about IV fluids, there's something called the Parkland formula that we use to figure out how much IV fluids you need. The one thing that we always talk about in burns is IV fluids. You don't think about a thermal injury damaging tissue enough to where it's deep frying your tissue and you're losing water that way. The problem is you've opened up the protective layer of your body. Your body's made up about 70% water, so if you make a big enough hole, fluids will leak out, whether it's initially, whether it's through evaporation. You still have to incorporate that amount of fluid when you're managing these patients, because a lot of times they will end up going into renal failure. So what we'll do is we use the Parkland formula. DECU is a good example. We have these numbers written around. What this tells us is the surface area relative to your entire body. So your head is 9% of your total body surface area. Each arm is about 9%. 18% on the anterior part of your chest and 18% on your back. Your thighs are not 18%. Your leg is 18%. So the upper is about 2/3. The bottom is about 1/3. Both sides. And then 1%. Some people might say they have 2%, but really it's just 1%. Kids are a little different. Kids have a big head, so for kids, that 9 is 18, and you take the other points off from your legs. The way I always remembered it in medical school was it was either big, medium, or small. If it was big, it was 18. If it's small, it's 9, and don't ever forget about 1%. So if you add all this up, you actually have 11 nines. So 2, 4, 6, 8, 9, 10, 11, 99, plus that 1, I keep hitting that, plus that 1 makes 100%. Parkland formula. So you take 4 milliliters of colloid, so that's normal saline or LR. If you're a medical doctor, they usually use normal saline. When we're doing large volumes for surgery, we always think about lactated ringers or LR. So 4 milliliters times the total body surface area times the weight in kilograms, not pounds, kilograms, that gives you a volume. 50% of that is given in the first 8 hours. So as soon as they come into the emergency room or the hospital, 50% of that volume, first 8 hours. The second 50% is given over the next 24 hours. So quick math, say somebody comes in with a 10% total body surface area. So you have 4 times 10%. We'll say they weigh 100 kilos. Okay? That in itself, as crazy as it sounds, is 4,000 mLs of fluid. If you have a 30% burn, you can see that this is getting a lot of fluids, and it sounds crazy, but it is absolutely necessary. So in this situation, you give 2 liters in the first 8 hours. So that means you just bolus it in over the first 8 hours, or you can break it up as a rate, depending on how much volume it is. And then the second is over the next 16 hours. So this person is getting a lot of fluid just with a burn. Now, when you think about a 10% burn, you're really talking about their entire right arm and this part, or their entire head in this part. It's a lot of destruction for a small percentage when you do that. But imagine if you're talking about a large catastrophe and you burn one arm and the entire front of your chest. You're almost up to 12,000 liters of fluid. So then that means you're given 6 liters of fluid in the first 8 hours. So that's almost a liter an hour. So it's just running, and then you taper off. If you don't do this, patients will get into rhabdomyolysis, they'll get into acute renal failure, and they will not survive. So that is very important. Parkland formulas on every test, every board test, any test that has to do with general surgery, emergency room physicians, whatever. If you're treating burns, you got to learn the Parkland formula. Now, patients in, we're getting them hydrated. The next thing is to look at that burn and figure out what they have. The first assessment is first degree, second degree, third degree burn. If it is a first degree burn, you pretty much don't need to do anything other than supportive care. So that means putting vitamin E, putting aloe on it, putting some type of lotion on it just to keep it from drying out. Remember, burns are not just a static injury. It happens, and then there's a transformation that can occur. So you can take a bad first degree burn, re-expose yourself to the sun, not do local wound care, and turn it into a superficial second degree burn, and then you have an issue. Second degree burn. You come into the emergency room and they say, okay, you have a second degree burn, Parkland formula, they give you the fluids. Oh, Parkland formula doesn't really apply to first degree burns. So you don't have to worry about getting 4 liters of fluid if you burn your entire back and your face. So second degree burn, Parkland formula, you get your IV fluids. This is where it gets tricky. A superficial second degree burn really only requires topical treatment. So that means something like Neosporin, bacitracin, polymyxin, some type of petroleum-based jelly to keep it moist and hydrated. What you're really doing is locking in any hydration so that your skin doesn't dry out, so it doesn't progress to a deep second degree burn that requires surgery. If you have a superficial second degree burn and it's watched and you use polymyxin, bacitracin, Neosporin, whatever, you can watch it and it will heal without a scar. Okay? Let's say it's a deep second degree burn. So a deep second degree burn is a little different. Deep second degree burn, that's when you start talking about silvadene, SSD, sulfosilvadiazine, all the same thing. What we do in that situation is we're worried about the dermis breaking down, and because it's open and exposed and it's a deep second degree burn, you can get it infected. So the silvadene is really good for preventing a deep second degree burn from getting infected. It also is really good for holding in fluids. The problem with Silvadene or SSD is that it is really, really bad about helping your body heal. So we put it on there usually in that first 3 to 4 days, 5 days, 7 days, to be able to determine whether it's a superficial or deep second degree burn. Once we realize that it's a superficial second degree burn, we switch from Silvadene to a polymyxin B or a petroleum-based jelly, so that the silver part of it, the sulfasilvadiazine, doesn't slow down healing. Any silver dressing slows healing, so just remember that. So it's not something that you would put someone on for 3 or 4 weeks. It's usually for a week, look at the wound, reassess it, and then switch them to something that allows them to heal. Let's say you don't do any of that. Then you can take a superficial second degree burn, turn it into a deep second degree burn. If you turn it into a deep second degree burn, you've basically taken a wound that was going to heal with minor discoloration and turned it into one that is going to heal by scar. So you will have scar formation. So that's the main reason you want to treat it, so you don't have to have a scar. You can also take a deep second degree burn, not take care of it, turn it into a third degree burn and require surgery, or it'll heal by scar, which happens in that, by real scar. So what will happen is you'll actually have the wound closed down. So you'll see somebody with a burn that has just kind of done its thing and scarred down and looks really ugly. Those are usually either deep second degree burns that have turned into third degree burns, or second degree burns that have not undergone wound care, and the body takes care of itself by contracting, scarring, and then they have problems and they need scar releases. As far as local burn care, the first thing you want to do is cleanse the wound. So you want to wash it away from whatever the insult is. Make sure it's clean and you're dealing with clean skin. Now, debriding is a tricky subject. If you have a blister, you can either debride the blister away and look at the skin underneath, or you can leave the blister intact and watch it. If you leave the blister intact, if it ruptures, you have to start all over. If it doesn't rupture, it will actually heal underneath the blister, and then you don't have to do any dressing changes. So you don't have to rupture blisters from burns unless you're worried about the burn being deeper than you anticipated. If the ruptured part or the burn part looks deep when we initially do our assessment, we will just rupture it and treat it like a superficial second degree burn, put bacitracin on it. If we don't know, we'll put Silvadene on it. And a lot of times in the emergency room, they'll put Silvadene on wounds and then have them follow up with the burn doctor in the next couple of days, just to make sure they're not missing anything, because the only thing worse than a deep second degree burn is a deep second degree burn that's infected. If you are with a deep second degree or third degree burn that needs to be debrided, we'll then do wet to dry dressing changes until we get ready to do a skin graft. If it's a deep second degree, Silvadene until it transitions to a superficial second degree, it starts to heal. Then you switch it to polymyxin, bacitracin, neosporin. If it's a superficial second degree, polymyxin, neosporin. The whole goal is to avoid surgery. Now, if something happens and you have a deep second degree burn that will not heal, or a third degree burn, you're going to require a skin graft the majority of the time. In certain areas, what you can do is cut out the burn and close it with suture. That's typically areas where you have a lot of skin, so sometimes we'll do that on the abdomens of some patients. You can do it on the armpits of some patients. You can do it if someone has lost weight. Sometimes you can close the wound, just cut it out and close it. And sometimes we'll do that on the hand. But if you can't close it, or it's across a joint that has to bend, you have to consider a skin graft. There'll be some video. There are some videos on the YouTube channel to go over how to do a skin graft, when it's indicated, and I'll put a good one up that covers a burn patient. But skin grafting creates its own host of problems. The biggest thing is that you got to get the skin from somewhere. We can do pig dermis skin that's temporary. We can do other types of coverings that are temporary, but eventually you're going to have to get human skin over it. If you do that, you have to get the skin from somewhere else. So you're actually creating another wound that is a superficial wound, superficial second degree wound that has to heal in order to take that skin and transfer it to the area of the burn. So that's one of the reasons that we only do this if necessary, and we're real picky about making sure these don't transition, because the patient will have to have a second wound. Now, one other thing about skin grafts, if you burn 10% of your body, we don't have to get 10% skin graft. We have a mesher, so we can make a 2-to-1 or 3-to-1 mesh. So let's say you burn 20% of your, let's say you burn your entire chest. What we can do is get the skin from both thighs, and we can take out 5% or really 8%, 10% of the wound, do a 2-to-1 mesh, and that will cover that 20%. So it's not a 1-to-1 ratio. As far as an outpatient standpoint, pain is the biggest complaint from burns. It's pain when they're burned, when they're undergoing healing, it's itching or pruritus. This is just the regrowth of nerve cells from where the dermis was burned and they retracted. You can also sometimes get graft rejection. That's typically either the wound wasn't cleaned, the wound wasn't prepared appropriately, you didn't do dressing changes long enough, or it's over a joint and someone is moving their arm or leg and it can't heal. The graft usually is left alone for 5 days if you're doing a wet dressing. If you're doing a wound vac, you can go 4 days, sometimes 3.5. If you leave it alone, it should take by neovascularization or growing of new vessels from underneath. It initially looks purple, not black, and then it turns back to normal skin, and then it undergoes what's called skin tumbling, where those cells basically tumble into the open areas on the mesh skin and fill it in. But again, I'll go over that in a surgical video. One other myth we talk about in burns, everyone says, well, if you can't feel it, then it's a deep burn, or if it hurts, it's a really deep burn. None of that is true. Burns can hurt, sometimes they can't hurt. Deep ones, you can go all the way through to the bone, and they're a little sore and they're a little tense only when you move them. So don't use your own pain as a guide as to whether or not you go to the emergency room. The most important thing is, if it's bigger than this, you need to go to the emergency room. If it's smaller than that, you can wait. When we give you instructions as far as this is what you need to do, you need to do it, because we're trying to save you from having to have surgery. Make sure you do Silvadene, and then make sure you do that follow-up in a week so that they can decide whether or not you need to switch from Silvadene to bacitracin or polymyxin. Silvadene, polymyxin, all of those need to be washed off every time you do a dressing. So you get in the shower, wash it off, apply it the next day. Next day, wash it off completely, get all of it off, take a shower, soap and water, do it again. Remember, the dermis is waterproof, so you're not worried about the water getting deep or anything like that. And even the subcutaneous tissue is waterproof. So water, soap and water, they are your friend. If the wound gets infected, it will progress to a deeper burn. Parkland formula, number of 9s, everything's a 9 or 18 except the one important thing. If you have any questions, DM me, text me, whatever. We'll get them answered. Hope this covers burns. Take care.
Ain't nothing wrong with thunder with the rain.